I'd like to welcome you all to the third annual Opioid Response Symposium. My name is Jackie Bowens, and I'm the President and CEO of the District of Columbia Hospital Association. It certainly is my pleasure to be here this morning with our great panelists and our teams. DCHA, as an association, as a member of the community, is committed to our partnership with the city's Live Long DC initiative and district hospitals to provide education that supports efforts to reduce opioid use, misuse, and death, and work toward ending the opioid crisis in the District of Columbia. This three-day event features local and national experts who will discuss the latest research, biggest challenges, and best practices for improving and ultimately saving the lives of the district's substance and substance use disorder populations. We hope that the information provided here will offer education and tools needed to provide effective care. Even though we are apart, we are grateful to provide this platform for us to come together around the continuum of care to address the opioid crisis. Thank you all for your work in the district, and I hope very, very much that you enjoy the symposium. And like everybody, certainly while we are apart and getting together virtually, I think we're all looking forward to that day when we get to be together once again in person. So in other words, go out and get vaccinated, everybody. I'd like to now turn it over to Ms. Gail Hurt, our very capable Assistant Vice President of Patient Safety and Quality, to introduce our first session. Welcome, Gail.
Thanks, Jackie. It is an honor to support this work at the association. And to kick off this year's symposium, we have back-to-back experts from DC Department of Forensic Sciences and DC Health to provide an update on opioid trends, testing, and composition in the district. Our speakers are Dr. Jennifer Smith, Dr. Luke Short from Forensic Sciences, and Keenan Zamor of DC Health. Dr. Jennifer Smith was appointed as the director of the Department of Forensic Sciences in July of 2015. Dr. Smith is a retired FBI special agent, having served for 23 years and was formerly faculty at Pennsylvania State University. Dr. Smith holds a Bachelor of Science in Biochemistry from Penn State and is a PhD in Physiological Chemistry from Ohio State and a postdoctorate from Harvard University. Dr. Luke Short is the Chemistry Section Chief at the DC Public Health Laboratory of the Department of Forensic Sciences. In this capacity, Dr. Short founded and manages the Forensic Chemistry Unit, testing evidence for controlled substances, the Clinical Toxicology Unit, testing for drug metabolites and other toxic chemicals, and the Mobile Testing Unit, a deployable rapid testing facilities for severe acute respiratory syndrome that causes COVID-19. Dr. Short is a technical expert for district legislative efforts on controlled substances, toxicology, and supports outreach to law enforcement and public health agencies. Keenan Zamor is a senior research epidemiologist with the District of Columbia Department of Health. Working in the Center for Policy Planning and Evaluation, he applies public health surveillance techniques to non-traditional public health problems, most notably violence prevention and substance misuse disorders. He holds degrees from Stanford University and Tulane University School of Public Health and has over a decade of public health experience as an epidemiologist. Please join me in welcoming our speakers.
Kenan, if you want to get started, you can share your slides. You should be able to.
Sure.
Perfect.
All right, so good morning. My name is Kenan Zamor. I'm an epidemiologist with the DC Department of Health, or DC Health for short. And we've been the last couple of years tracking the overdoses as they happen. As you know, it became a problem starting 2014, 2015, when we really started seeing unusual numbers of drug use and overdoses in the city. So DC versus the rest of America, that's something we always point out, is that our picture is very different from the national landscape. We have a different core group of users that are driving this epidemic and the numbers that we're seeing in terms of deaths and non-fatal overdoses. So our average addict is older, maybe about 52 years old. There's a lot less racial diversity. It's almost 85, 86% Black. And these are people who are not novice users, who've been using for a very long time. And there's a lot of concentration in where this is happening in terms of our certain neighborhoods, mostly in Wards 5, Ward 7, and Ward 8. So the first thing we do is surveillance at the emergency department. We have a system called Essence, which pulls the chief complaint and discharge diagnosis of every ED encounter. So we really monitor that over time and look for an unusual number. We can also look at patients with a history of opioid abuse who present with another issue. Like I said earlier, our average person is 52 and has been using drugs for over 20 years. So we see a lot of other chronic diseases like uncontrolled diabetes, hypertension, things like that in terms of care consumption. But this is an undercount since a lot of our overdoses decline transport to the hospital. So fire and EMS data is always going to be more reliable to track this. So if you look at the numbers over the last couple of years, 2017 was our big year where we had 279 deaths. We went down in 2018, 2019, and then COVID happened. We jumped up a bit. Not terribly significant, but it was enough to cause some concern. And if you would look at the deaths, you'd see we had 408 deaths compared to our previous high, which was 279 in 2017. So far, we're at 394 as of yesterday. So we're on pace to be below that 1153 number. So what we can tell from this data, and this helps inform our prevention efforts as to who to reach out. We have an average age of 52. Non-DC residents who overdose here are actually significantly younger. They come in at 45. Wards 2 and 3 are actually our youngest wards at 43, and Ward 5 is the oldest at 54. So we've seen a decline in age from 53 in 2017 to just under 49 right now, and that's being driven largely by Ward 2. The gender split is pretty consistent, 7-3 male to female. And like I said, we're seeing a surge in Ward 2. That's coming up for 22% of our overdoses citywide now. But my favorite data source is our fire and EMS data. And because that tells us the location where the overdose happened, hospital data just tells you their zip code of residence. You can't really find out more about the actual event. So in terms of informing prevention, this is the best source. So we look at naloxone administrations with a documented improvement in the patient's condition. And we also get the impression from the first responder. The good thing about this data is we have identifiable information. So we have name, date of birth, we have their home address, we have where it happened. So we can link that to a variety of data sources. So the biggest thing we do with our fire and EMS data, and this is publicly available, it's called ODMAP. So it's the Overdose Detection Mapping Application Program. It's run by the High Intensity Drug Trafficking Agency out of the Baltimore, Washington area. And so we're basically able to plot every overdose on a map within about 15 minutes of the event. And this is publicly available. I'm going to share the information on how to get it. I can actually do it live for you right now. So this is ODMAP right here. You can see this is the last month. We've had 119 overdoses so far for April. The purple dots are going to be where the person got multiple doses of naloxone. So that's kind of a surrogate for the strength of what they were taking. You can also do a heat map if you'd like. So that'll show you some of the hot spots at 16th Street Corridor, Chinatown, and Ward 8 especially. And this will also show you national data. So if you're a big nerd like me and you want to see what's going on in the rest of the country, you can check that as well. So this is the sign-in information. I'm guessing this will be shared so you can use this to jump on and see the data. And it will also give you weekly reporting, and what we do is spike alerts when there's an unusual level of activity. Right now, it's more than 7 overdoses in a 24-hour period. We send out information to everybody that wants it. So our typical EMS transport is a little different. It's a little younger. It's 49 years of age, 88% African-American. The gender remains the same, but what we've seen is a rise in repeat overdoses in 2020. We're seeing people overdose multiple times in a 12-month period, and that's becoming very concerning. So about a third of our overdoses decline transport. That's very concerning because we have the induction programs at all our facilities. So that's a missing encounter right there that could be happening. And also it's against medical advice and potentially dangerous that they could overdose again. So with these repeat overdoses, we're seeing a larger proportion of overdoses being people who have overdosed in a 12-month period. The biggest we had for 2020 was 8 for one person. So the average time in between these overdoses, it's about 3 months. And the shortest I saw was 1 day. And we're seeing a lot of people overdosing actually 2 or 3 times in 1 week, which is very strange. So the biggest predictor for that is going to be the location, overdosing or living in a known hotspot and having a previous refusal of transport. So these are our overdose encounters in the last couple of years. 2021 and 2017 were our biggest ones. We're slowing down. We're getting back to average really for 2021. So we expect our numbers for 2021 to be below what happened in 2020. So in terms of neighborhoods, our top 5 neighborhoods, it's going to be Chinatown, Trinidad, U Street, Columbia Heights, so that whole 16th Street corridor, and then Lincoln Heights. So this is information we share with prevention. They use on a weekly basis to decide what neighborhoods they want to go to. And we actually get a lot more granular and we tell them where and when these overdoses were happening. So this can be used to inform where to deploy resources, where to deploy advertising, where to deploy naloxone, and outreach efforts. So another system we use in collaboration with the medical examiner is called our state unintentional drug overdose reporting system. So we look at extended circumstances surrounding a fatal overdose using their fire and EMS run sheet, their death certificate, and their autopsy report. What we're finding is that bystanders are present in just under 1/3 of the deaths, but most of our fatalities are not receiving naloxone. The toxicology is overwhelmingly fentanyl, but we're also seeing a large portion of polysubstance use. We're seeing a large rise in cocaine in our deaths, and I think Dr. Short's data should touch on that as well. But also we're seeing that most people are dying at home. So as far as the linkage to prevention from surveillance, we really have 2 key roles. We try to detect and we warn of unusual patterns. And the way we do that is just by tracking what the numbers are and seeing what's unusual and what's not. And then we feed data for targeted interventions when that happens. So sending people to the hotspots, if we're seeing an unusual amount of overdoses in one area, we basically flood that area with either naloxone or peer responders. We do a lot of screening, brief intervention, and referral to treatment. And we can also apply that approach to multiple drugs, not just opioids, but also evaluate treatment effectiveness. And that's a little tough with some of the privacy restrictions around substance use treatment. But we are seeing being on methadone or inactive MAT is emerging as quite a risk factor in terms of overdosing and death. And we'd really like to explore that more. So with that, I'll pass it to Dr. Smith and to Dr. Short for their presentation.
Thank you very much, Ken. And Luke's going to put up our PowerPoint. Once that's up, we'll begin. I just want to say good morning to everyone, and thank you so much for your interest in this topic. I am Jennifer Smith. I'm the director of the Department of Forensic Sciences. And I'll kind of give a very general overview. The Department of Forensic Sciences has many activities We are, in a sense, the city's crime lab. We also have the public health laboratory, and we have a crime scene sciences division. So today we're going to talk about our opioid surveillance program in the district. Luke, if you want to go to the next slide, that'd be great. So here is what's interesting about the Department of Forensic Sciences, because we have both the responsibility to do science in support of law enforcement activities, as well as science to support public health activities. This program is a perfect merger of those responsibilities. So as you know, the drug supply and what's in the illegal substances that are circulating on the street has many different impacts. And the most probably important impact is its danger it presents to the people who are using those drugs. So if you only look through this as an optic of, is this heroin and are we going to arrest somebody for that? That's not actually very helpful. And so the Live Long DC program and the activities that the department runs in support of that is this surveillance program, which allows us to use the same chemistry to identify dangerous drugs to actually understand what else is in those drugs, what's in our supply. So we can use the same chemists to do both jobs, but our philosophy is broader than your traditional forensic chemistry group. So this surveillance program, which started several years ago, allows us to take drugs that were originally collected from the streets in order to characterize those, so these illegal drugs, to see what's in them. We have gotten funding from CDC, so not through a law enforcement source, but actually through public health sources. So CDC, as a part of this concern for the opioid crisis that was happening, actually wanted to see more surveillance activities. So we were able to establish this in our forensic chemistry group, the surveillance program. We provide monthly reports to community stakeholders or anyone that's interested. We provide presentations such as this one to communities who have a concern about decreasing the amount of deaths caused by these opioids and dangerous drugs. We also support intelligence about the emerging drugs that are out there. We try to describe the trends that we're seeing. And as I said, we really want to make sure this data gets into the hands of anyone who can find it to be useful. So I encourage feedback after this presentation back to myself, back to Dr. Short, so that we can make sure we're answering the questions specific to your target group. So next slide, please. So this is what's important about kind of how this drug surveillance model is working. We look at the supply, the drug supply, and we get samples from traditional law enforcement partners, Metropolitan Police Department out there collecting, the jail from our Department of Corrections. So those samples are collected. The lab can look at what's in those to get a good feel for what's on the streets. We're also utilizing syringes, and Dr. Short will share information. These are syringes that are turned over as a part of a syringe exchange program. So we can use these syringes, and we have some amazing partners who are helping us look at those syringes to give us a closer look as to how the drugs might be utilized. We have access to toxicology testing, so that information can feed into this, as well as syringes we get as a result of death. So we call those our overdose syringes. So by looking at all these different sources of drugs that are coming in, we can provide the type of information that Dr. Short is going to provide to you today. And again, this has evolved. At first, we were sort of starting with the overdose syringes and some of the street drugs that were brought to us. And it has evolved into a much larger program as we try to get a broader perspective of what might be in use in the community. And again, the sole purpose of this is to inform to either dangerous trends that are occurring or changes that are happening in our drug supply as a warning to individuals to prevent death from the use of these drugs. Next slide. So this just kind of gives you a general metrics of how the program's been running. The funding that we have supports the various chemists that are there, a supervisor and 5 chemists. We also have some additional support to help us with the statistics. as the drugs come in, they have a pretty good turnaround time of 30 days. They're able to report out these results, and 100% of their cases have reported within 60 days. And again, this has been a healthy way to utilize the surveillance program to also support any law enforcement actions that might come from this. Because if we're actively looking at samples as they're coming in, even before an investigation may be needed, if we're looking at them as a surveillance program, then we are actively analyzing those without a court date request. So when we look at white powders, when we look at what's going on, our first priority, in a sense, is to support this surveillance program. And you can see how the types of exhibits that we've looked at has grown over time. So next slide. This is where I'm going to turn it over to Dr. Short. Dr. Short is really the brains behind this whole program. I'm fortunate that I get to introduce him at meetings like this, but Dr. Short has really spent time watching this program, growing this program, and supervising this program. So I'm going to turn it over to Dr. Short, and he will carry you through the rest of the slides with the more detailed information of what we've seen so far. Dr. Short?
Thank you, Dr. Smith. As Dr. Smith has mentioned, this program has grown over the years to encompass a greater portion of opioids for analysis in order to provide a surveillance net for emerging synthetic opioids, as well as a determination of where are these new synthetic opioids within the district. So what we see here is sort of a summary workflow of how the drugs, when they are first picked up during surveillance, are brought into the unit via a surveillance query that we do against the evidence that is stored on file on queue through MPD. We review that independent of law enforcement and any kind of prosecutorial request to see what is most important for the district regarding synthetic opioids or potential emerging synthetic opioids. So we look at pills, we look at certain powders and such, and then we take those and then screen them within the unit to be able to look for any kind of emergent chemicals. This information then allows us to be able to refine this method to better target different drug types in order to surveil that group as well. So in this slide, we see sort of a shift that we've noted over the years as we began in 2018, early 2018. Most of the drugs we saw sort of broke down into two general categories, predominantly as heroin, although there were some emergent amounts of heroin that had been laced with fentanyl. This slowly took over year on year through 2019 and 2020, in which you first had a more ubiquitous amount of contaminated heroin with fentanyl, until eventually in 2020, you had a new trend emerge of just pure fentanyl, and then heroin started to wane. If we look at from today back 1 year, what we see sort of what is the current picture, you can see that there's essentially isolated distribution of heroin in more the east northeast region of the district, whereas in the western and southwestern is predominated by fentanyl. We are also tracking tramadol, which is appearing recently in some of the samples we're taking. And so we're monitoring that as far as changes in potential user behavior or drug supply requests within the district. And the big difference is something that you'll see more on the next slide with regard to how these trends have changed. So going from left to right, we're starting at around January of 2018, all the way through January of 2021. The district has essentially gone through three different phases in which you had a period in which it was mostly heroin and fentanyl laced heroin leading through most of 2018 through part of 2019, a brief transitional period, and now we're sort of entering in a new period where you have a bifurcation of the drug supply into either fentanyl or heroin, but the mixtures have greatly receded. And this is a very interesting trend in that fentanyl is a lot cheaper than heroin, and so there's probably a market pressure on that. for the drug, and as it's sort of making general market acceptance, as it were. You can see from 2018 early to 2021 now, the yellow line has slowly gone up. And that's just showing that fentanyl has now become more of a mainstream drug. And then heroin is sort of taken as a side as being recognized for itself as being an alternate drug, but not the cheaply available drug that fentanyl is. This is sort of an interesting slide to show just how it has not only been fentanyl that's increasing, but the period of around 2018, 2019, when we first had all these concerns about fentanyl analogs on the market, has also changed dramatically. We first had things like fluoroisobutyl fentanyl, acetylfentanyl, all the way down to things like carfentanil that were appearing in the market a couple of years ago. And the concern was that you would no longer be able to regulate all these new drugs, and that you wouldn't be able to test for all these new drugs, and how would toxicology be ready for something that's emergent. And what the picture appears to show is that actually what's happened is that it was sort of almost like a Darwinian selection process of the fentanyl analogs. And the one that was cheapest, presumably in some cases at least, it was less lethal and more widely available. The fentanyl has sort of dominated now over these other fentanyl analogs. And slowly it's weeded out the other analogs, and they've dropped away. Where this is significant is that if you look at both for monitoring, it simplifies it in the toxicology realm, but also in the more commonly seen sort of user awareness realm, where you have these fentanyl test strips. At first, we were very much against using test strips to check for presence of fentanyl because of the concern of fentanyl analogs not being visible in these powders. Now it's actually looking like you have more and more just fentanyl. So there's a good chance that if there is an analog present, it is fentanyl, which should be indicated by those strips. So 2021 is definitely a different world than 2018, where you had a lot of analogs present. As Dr. Zamora was saying, we had also a very good amount of information for overdose syringes versus the syringe exchange program. And what's interesting in that, when you look at the last several years of information, we have more information on the overdose syringes than the surveillance, syringe surveillance, which has gone back only since last November. But in this time, we've seen a clear pattern of what makes something or what is associated with something that's deadly versus not. With the syringe exchange, we see relatively little cocaine, and we see relatively higher levels of amphetamine type stimulants, everything from the more synthetic cathinone types like Eudalone and such, and methamphetamine. Whereas when you look at what's associated with the death investigations, you have a lot more cocaine within these syringe populations and a lot less of the amphetamine type stimulants. And so those two things sort of jumped out at us when we were looking at comparisons to feed back to the community and tell people, look, when you mix cocaine with heroin, it does appear to have an association with a higher mortality. And that is definitely something we want to reach out to the awareness of the drug using community within the district. Cocaine and heroin are definitely a deadly mixture. When we plot this geographically, we found it interesting because of not only supporting the idea that these things are deadly, but also when they're not deadly, why. So here we have a map where you have blue is the cocaine, yellow is the fentanyl, and then when you look at the syringe exchange program where you have mixtures of cocaine and fentanyl, that's in red. We found a high correlation between our data and what the medical examiner's office said were the overdoses in most of these regions. And so usually where there's red in one, you find a higher incidence in the other. The part that we found interesting was that when you look around places like Georgetown, you have a lot of incidents of both cocaine and fentanyl in the syringes, but you don't have a concomitant increase in the mortality. So one possible reason that we want to explore is that this is just to do with the higher amount of available naloxone. It could be a social context use, but whatever it is, this is the one exception to the rule of mixtures of drugs leading to higher mortalities. And so we think that we might have lessons to learn from that community to see what's going on there to help mitigate the overdoses. Now, something else we've been monitoring is the pill or illicit or gray market pill production within the region and being sold here on the streets. And what's fascinating is when you look at 2019 to 2020, you see yellow are the actual oxycodone pills. I'm sorry, blue are the actual oxycodone pills, and yellow are the fake oxycodone pills that are actually, using fentanyl in place of oxycodone. Back in 2019, most of the pills that were picked up within the surveillance program were actually just, actual oxycodone pills, diverted supply from a legitimate source. What we saw towards the ending of 2019, then more and more through 2020, and continuing through 2021, is that the appearance of these illicit, look-alike oxycodone pills increased consistently to the point where now just about 1 out of 2 pills that you see on the streets are not oxycodone, but rather fentanyl. This has implications for people within opioid treatment programs in that when they are seeking medical attention, when you view their toxicology, you have to consider that they may not deliberately be using fentanyl, and to not, I would say not necessarily accuse them immediately that they are using fentanyl, but go more into the case history and ask them, are you taking oxycodone pills where you know the source, or are you on a prescription? If you find out that they are actually taking them from an unknown source or potentially illicit source, it's very important to make them aware that many of these pills are not actually oxycodone, but contain fentanyl. That's a continuing and ongoing presence within the district. So one of the efforts here very recently is now that we have some information, about almost half a year's worth of information on the supply as is being used. So within the syringe exchange program, as well as the supply that's being picked up from the surveillance of the powders. So sort of the source versus how it's being used. We're beginning to see at least the first inkling of a trend where you have about a half-year delay between what's seen on the street. So you have, for instance here, from 2019 to around mid-April 2020, you have an increase in polysubstance use seen in seized drugs. And then about half a year later, that works its way into the population of drugs that you see in the syringes. And we're hopeful that by monitoring over the next year or two, we can see more correlations between this surveillance network of the street drugs being mirrored in these syringes. And this is one of the benefits that we have within this particular public health lab program, is that we're connected with forensic chemistry of what the drug supply is directly with the syringe exchange program for public health. And that allows us to be able to go cross-disciplinary to take the information from sort of more of a public safety arena and apply it to a public health arena for awareness and preparation, so that when we do see similar changes in polysubstance use, we can be better prepared for the next change in user behavior and potentially higher mortality rates. And so what this also shows us is that recently we've seen a drop in polysubstances within the drug supply. And so we're predicting now, a couple months out from now, we believe that if this trend continues, that there should be a drop in polysubstance use within the syringes, which hopefully would also then translate into fewer deaths. But like I said, this is still a work in progress, and we're just still collecting data. And like any surveillance program, its power is in the length of run rather than the intensity that you look at it. And so the longer we can run this, the more valuable this information will become. So I was going to call there quits, but I was asked to provide also a little information on synthetic cannabinoids. These are not synthetic opioids. I know, but we also do monitor synthetic cannabinoids within the district. And I was told that some people on this call might be interested in knowing some of the top synthetic cannabinoids. So here they are for the last year. We have MDMA-40 and Pinaka as being the dominant synthetic cannabinoid, which is pretty consistent across the United States. It also, just like how fentanyl became a lot more dominant this last year, it has become the dominant synthetic cannabinoid. And what is sort of anecdotally very interesting is if you look at all the way at the bottom, what is affectionately known as FABAM, which is the MMB Fubinaca, that was the big drug back in the heyday of 2015 when all this got started, as being the synthetic cannabinoid that was responsible for all of these spice problems or spice epidemics we had in DC, where you had mass incidents of people, dozens of people passing out. And now that is almost unknown. It's very rare now. And we've had all these other drugs. So I guess unlike the synthetic opioids, the synthetic cannabinoids have definitely maintained their diversity of chemical population. So that is it for me. And I will close this and ask for questions.
Thank you so much. We really appreciate this insight. I think it provides information for those who are caring for patients in our hospitals in particular, and our outpatient providers, and some of the things they might be seeing or could anticipate as they're trying to plan their programs. And one of the things that someone noted as a question from the audience is, Kenan, you mentioned forms of medication used for addiction treatment are causing overdose. What are some of the recommended strategies to address this, given that we continue to try to battle against stigma of MAT, particularly methadone? Are there any strategies in the public health sphere that are focused on how we might address the overdosing on forms of medication that are typically used for MAT?
I think the biggest innovation is really a connection and constant communication among people who have a relationship with that patient. What we're finding is a lot of people with a prescribing relationship with a patient don't know that they overdosed 2 days ago. So that would really help, and you would treat that person differently if you knew what was going on. So that's very difficult. That level of data sharing, especially with 42 CFR, is hard to get. But I think that's really the goal as we build out health integration. But what I think this methadone showing up in the top screens is really indicative of relapse. And I think there's a real danger, and I think the repeat overdoses is showing that. But there's a very dangerous time after somebody overdoses. So that's why it's very important to get our refusal rate down, and to also try to get in touch with people after they refuse transport to the hospital in the community.
Right. Thanks.
I think to add a comment onto that, that's something that we've been discussing also within the opioid treatment community, that within the drugs that we see in the district, we don't see methadone. It's not present, which is suggestive that this is a legitimately used drug, and that it, as Kenan had just said, this is an individual who has been on a methadone treatment and has relapsed because it's not working for them. And this is something I think that would underscore the need to do more research and to understand what is an appropriate methadone level for someone so that they don't go into relapse. And that's something that we've been trying to push, and I think we are making a lot of purchase on in being able to quantify methadone with an individual as they are admitted to a program, and be able to monitor this level to see whether or not it's efficacious, or if they're taking other drugs, for instance, if they're not getting an effective level of treatment. So more information is definitely better on all this.
Right. Well, and that's actually, I'm glad somebody asked that question, because I actually presented some insights for clinical treatment that I hadn't really thought of, and provided a slightly different context in that, for example, the methadone may be present in the sample, but not necessarily what they overdosed on per se, but maybe more indicative of relapse. That's actually very helpful. Thank you. any information on what might be driving the reduction that you're seeing in combinations in the samples, heroin and fentanyl being seen less? I think that was the second to last slide. Do you guys get any data that gives you insight into why that might be, or is your data limited to, we can see the results and we can't tell you anything about the trend, what's driving that trend?
Well, I do think cost is probably a part of it, and Luke can talk to this too. Fentanyl is much cheaper and pretty readily available. So again, if the effects are felt and there's no danger now associated with it, or less danger associated with it, at least in their heads, then that I think is partly what we believe might be driving this. Luke, do you have any more on that?
Yeah, I would say, the one big thing is supply chain is a lot easier for fentanyl. It's cheaper and it's more of a point-to-point. You can order it from abroad and they'll ship it to you. Heroin has sort of a different supply chain, goes through a different mechanism to get into the district. So for a couple of reasons, it's not as adaptable as what fentanyl has been. And as Dr. Smith said, it's a lot cheaper.
Right. So market forces, quite frankly, interesting. This may be more a question for some of our other public health officials, but it came up, so I'll ask in case you know the answer. You mentioned fentanyl test strips, and I know there have been some recent action on the federal level in terms of changing some of what's allowable around distribution of fentanyl test strips. Are those available in DC, do you know?
So they have been adopted by our harm reduction community, but previously we were restricted by our federal partners from using them. That stance is softening right now, so it's probably an idea we may explore.
Okay. All right. Sounds like somebody may be interested in that. I think this is actually a really important question. How can hospitals contribute to the DFS sampling and analysis? I know you get a lot of your stuff through your collaboration with MPD. I'm curious about how hospitals can potentially contribute to that if they have samples.
Well, I think that's a great idea, and we're glad you guys are thinking that way too, because again, it's really trying to get the broad spectrum of use. And so Dr. Short has had some ideas of some programs that maybe could work, but it would take extra effort on the hospitals. And so we didn't want to promise anything, but we could certainly set up programs if there was a hospital that was interested in this. So I'll turn it over to Dr. Short because he has some ideas.
Sure. I mean, for us, there's sort of a short-term versus long-term. I very much cherish the ability to have short-term demonstration projects where a hospital could send us a lot of specimens and we can demonstrate to them what we can do with those specimens as far as reporting and sort of an in-depth look at what's going on there. Now, there's different ways of approaching this. Either we could do it where it falls under general surveillance that we're doing under our current existing surveillance program, where one hospital groups all their urine together and we get just like, a dozen specimens every month and we monitor that. But if we actually want to have, much more in-depth analyses, we're going to have to work some sort of ability to fund this program as we, look at per person analyses. And that gets a little more complicated. And that would require a little bit more of an offline discussion with the hospital to discuss how we could, provide the service for per person that is a clinical test in support of what they're doing.
Right. I think that also begs the question of connecting toxicology and what someone has on board with their clinical presentation and their outcomes. So I think in the future, that's going to be a very interesting research question to answer.
Well, I mean, one of the other aspects to that is something I'm trying to push is sort of the next step for us as we go from looking at clinical toxicology for an individual, for instance, on an opioid treatment program. The same instruments used for looking at their toxicology can be used for the chemistry. And so what's their liver doing at this time? What other factors within their body would increase or decrease, the response to some sort of opioid treatment, or be a red flag for someone if we have to be more aggressive or even soften what our treatment is. And so I think providing just toxicology is the beginning to a much more in-depth panel on the individual's chemistry.
Yeah, and that latter point, I think, brings up you're providing the samples to get data back in aggregate form in something like this is helpful, but to the degree that we can maybe even dream something more sophisticated that actually would provide feedback directly back to the clinicians in terms of helping them in provision of care would be probably an addition that would make the care more effective and provide some immediate return on, feedback on the information that's going out the door.
Yeah, I think that would be great. And I'm reminded of when I first arrived, I think it was 4 or 5 years ago, there was a K2 pilot project where we worked with hospitals to try to do sort of the toxicology on some of the folks that were showing up. So if there is a hospital out there that wants to enter into a partnership on this, we certainly would like to hear from you and try to sort through working with DC Health, how we could at least pilot an initial study and then maybe take it to a more broad study if that's possible.
Jotting down notes on that one so we can get back to our hospitals, because that actually sounds like something that would be interesting, depending on level of interest, of course. Here's an interesting one. What do you recommend on potential sort of simple or straightforward ways to share some of this data with patients if you're trying to, have brief interventions with them and talk to them about what the implications of use would be and that kind of thing? Have you guys given any thought to how this might be easily presented to patients or in a public, messaging campaign or anything like that?
Well, I'll just say generally, Dr. Short is available for any presentations with individuals who deliver that type of information for you. We certainly give sort of our monthly reports and there's a standard format to that. But I think what we found is the more interaction we have with the people who then share that message, the better we can provide that and put together flyers or whatever. So we don't always know every mechanism by which people talk to their patients. And because this is also evolving data, gets a little tricky. What if you put a flyer together, it may be out of date in a year. So right. We would love to, and Dr. Short is available to do speeches or presentations. We have other individuals too. So we want to make sure we push this out to any customer that can utilize it as best they can. And we work with DC Health too. I know part of the Live Long DC program, there is a sort of campaign of sorts that is running on that. But we're happy to work directly with any provider who feels this type of information they could utilize and take to their patients.
Yeah, that's great. And I know several of them are on the call here. The peer workforce that works with the hospitals have sort of a monthly collaborative meeting themselves where they talk about some of the things that they're struggling with in terms of barriers and collectively address those and talk to community providers to ensure we've got great connections for coordination of care. I wonder if that might be a mechanism for us to get some feedback from them about how it might be helpful to share this in some fashion. When we asked you to come back, it was because we got a lot of feedback from clinical folks that this was helpful to provide insight from them. And I admit I had not thought about how do you then share this data with the patients and perhaps should have. Do we have any insight into what led to the sharp increase in 2020 in overdose deaths? Do we think it was related to the pandemic? I know I've seen some data on more folks being at home as opposed to out in the community, and actually some messaging and campaigning about don't do this alone and that kind of thing. Any other kinds of insights that we might have on what drove that increase?
I think, the biggest thing is the isolation that came from the pandemic, and that led to things like supply chain disruptions, and just people were finding it harder to connect with their dealers, were going to dealers that they didn't necessarily know or trust. But you couldn't really stand outside without sticking out. But I think the biggest issue is just the general challenges to mental health. People with, substance misuse disorders are going to be slightly less resilient in a situation like this, which is just massive worldwide disruption, and people turn to drugs. And like Dr. Short's testing will point out, it's 95% fentanyl out there. Every encounter is dangerous, especially if you use alone. And given that people were less likely to congregate, I think that definitely had an effect on it.
Right. I have one that's come up twice, and I was sort of saving it for the end, but we might have time for another one after this one. But since it came up twice, I'm going to go ahead and ask it. Is this reflective of trends around the country? I know to some extent DC is unique in that we're sort of urban and closed in, and trends you might see around the country, if they're state-based data reporting, may include states that have cities like ours, as well as sort of rural patterns in terms of their development. But is this similar to trends that are being seen around the country? Do you know?
It is. I mean, some places more or less pronounced, but there's just been an increase in morbidity and mortality nationwide. The CDC actually just released a document the last couple of weeks ago, so I can share that with the group as well in the chat.
Oh, that'd be great.
So yeah, we don't fare very well in that document because of our numbers and the fact that we are a strictly urban jurisdiction. So it's us in West Virginia up there as the top two.
Yeah, I think West Virginia is just starting some of this work too. I know some of the partners that we work with are starting to work out there and learn from that. So here's an interesting one. Do you have any metrics or data available on social determinants of health that might provide a color to some of the stories that you're able to tell from the toxicology and chemical analyses that you do?
Could you repeat the question? I'm trying to see. So do you mean stories?
I think they're thinking about, if I'm trying to, I'll rephrase the question in a minute. If I'm trying to envision what's happening, what's underlying these patterns and trends, why might this be happening, to try to avoid it? I think they're trying to make that connection in their minds about, are there some other social determinants of health factors that might be contributing to some of what's happening with folks. So I'll read it because the way it was worded originally might actually have been a little bit better wording. Are there any SDOH metrics that you look at that would help tell the story in conjunction with the data?
Well,
or have you even thought about that?
Yeah, one thing that we do, we participate, both Dr. Zamora and I participate in an opioid death review board panel, which actually looks at individual cases. And I think that from that, then recommendations will be made as to maybe broader things or programs we need to do or programs we need to tweak. So DC is trying to take the time to kind of dig into that in relationship to the individual and what services they provided and things like that. That might help inform some of these and provide sort of broader perspective. Kenan, I'll let you jump in on that too.
Oh, you're muted. Oh, and now he's frozen. Nope. Yep.
What we usually see is that some of these bad outcomes just tend to group together. Like if we overlay violence and overdoses, it's exactly the same map. So when we look at poverty, when we look at deprivation of opportunities, educational inequalities, these things all tend to happen together. But we're just moving into the prevention space now. I mean, most of that work has been done by the Department of Behavioral Health. So as we gain more experience in that area with our rapid peer responders and some of the community outreach we're doing, hopefully we can address those collectively.
Right. And it sounds like the review board, not necessarily this group, although you're part of that, is taking a deeper dive into looking at contributing factors such as social factors as well as others. I know in some of the other reports that I've heard around that group is they also look at sort of the coordination of care and folks lost to care has been a big factor that they've been looking at as well. So the more we learn from that, I think the better we can be if we're trying to expand that out in some fashion and targeting the right metrics and not just throwing everything at the analytic. Great. I'll just one more question. I think we have time for one more. Do you know where the fentanyl and tramadol are coming from? Diverted from hospital supplies or elsewhere? Do we have a sense for where the source is in terms of the supply?
So I mean, the form is a powder for like the fentanyl and stuff. So I mean, that's not something you would see in a hospital. It would come in as an actual a vial or as a patch. This appears to be an illicit supply. I believe internationally, most of it comes from China, but we're getting the illicit version of it, the powder.
I think that's helpful to know. Not that our hospitals will take their eye off the ball, but they're probably thinking, wait a minute, where's that increased supply coming from? Just a note for folks who were interested, Elizabeth did post that link that Kenan mentioned in the chat, if you're interested in pulling that for your information. And I just want to take a moment to extend my personal thanks to our wonderful speakers, Jennifer Smith, Luke Short, Kenan Zamore. We really appreciate you presenting in these and other forums. As I mentioned, it really does provide, I think, great insight for us as we're thinking about how we tackle this collectively. It's not, if it's not data informed, then we really are struggling a bit.